this morning. And thank you all for attending this, which will probably be my last Grand Round since I'm going to be retiring next June. Today I'm going to be talking about the effects of mild traumatic brain injury. And the objectives are really fairly simple. I want to talk initially about what does and does not define mild TBI. I'll often use the term mTBI for that. I'm going to talk about some of the common methodological limitations in research in this area that, for you to be a good consumer of research, will be helpful to know. I want to also talk about the natural history of cognitive recovery following an mTBI, and what are some of the most common causes of prolonged post-concussive syndrome. And finally, hopefully we'll have time to touch briefly on the future risk of developing dementia following an mTBI, since that is a concern that I've heard from many patients over the years that have had an mTBI, are finding themselves a bit forgetful, and are worried that maybe because of this head injury they're at increased risk of dementia. And so this is an outline of my talk, and we're going to begin first with the diagnostic criteria and risk for mild or more severe TBI. And we have to begin with this homage to Teasdale and Jennett, who half a century ago published a scale, the Glasgow Coma Scale. They were from the University of Glasgow. That is widely used today throughout emergency rooms and by emergency personnel. And it really defines nicely how consciousness is on a continuum. And we impose a dichotomous conceptualization, and that is Glasgow Coma Scale scores, GCS scores of 3 to 8 are typically taken as signifying coma or unconsciousness, while scores of 9 to 14 signify altered consciousness, and a 15 means that a person is fully conscious and aware and alert. Now, the Glasgow Coma Scale score figures prominently in pretty much all the classificatory systems for grading the severity of traumatic brain injury. Now, the DSM-5 TR classification, this is fairly new for the DSM system to introduce a classification. Many others have been more widely used, the American College of Rehabilitation Medicine and a VA system. There are at least 40 published and used systems to classify TBI severity, but they're all remarkably similar. There's a much more overlap than differences among them. And you'll notice on the two left-hand columns of uncomplicated and complicated mild TBI that they're both essentially the same. They're defined by a loss of consciousness of no more than 30 minutes, a PTA duration, post-traumatic amnesia duration, no more than 24 hours, or altered mental status, same length, and by 30 minutes post-injury, a Glasgow Coma Scale score of 13 to 15. The only difference is whether acute brain imaging shows an abnormality. And that could be a contusion, it could be a bleed, it could be any number of things. A skull fracture even would be enough to sort of call it a complicated mild TBI. Moderate and severe TBI simply have longer durations of unconsciousness and post-traumatic amnesia. Most people will define them as mild, moderate, and severe, but there are many systems that will also include extremely severe, and these are usually for people who have post-traumatic amnesia lasting more than a month, who are in a coma for more than a week, and sometimes, and many systems will talk about catastrophic brain injuries, which really refer to the likelihood that one will never regain active brain function above the brain stem. In other words, a persistent vegetative state. So notice, very importantly, that no symptoms, no reported symptoms figure into this schema or any other. So a patient telling you, I had a head injury, I hit my head, and ever since I've been dizzy and having headaches and whatever symptoms they report, that is not diagnostic of a TBI of any severity. These are the criteria that are in that table. So what is the prevalence of traumatic brain injury? This is results of a pooled analysis of 82 studies from 5 continents, and they found that across all studies, the annual TBI incidence was about 349 per 100,000 person years. So if a person lives 75 years, this would equate to about a very crude back of the cocktail napkin estimate of about 26% of people that by the end of life will have sustained a TBI. And of course, men are far more likely than women. This is across all ages until very late life, when that evens out. And the severity in most cases is about, in about 86% of cases, these are mild TBIs, and the remaining 14% are moderate or severe. Now, what are risk factors for TBI? In this pooled analysis, they found some very clear things. Being male, males are twice as likely. Being a young male, 15 to 34, or being a person over 65, usually related to falls. Bicycle and motor vehicle accidents, so driving, riding a motorcycle, riding a bicycle, not wearing a helmet, playing contact sports. There are a variety of things that clearly are well replicated across studies as risk factors. The point being that these do not occur randomly in the population. But are there other risk factors? This is a wonderful study that came out of Sweden in which the investigators followed nearly 306,000 Swedish men who were conscripts into a mandatory military service. And before being assigned into the service, they had to go undergo an evaluation. The evaluation lasts 2 days. They get cognitive testing, including kind of IQ testing. They get all kinds of physical testing. They take an extensive history. They learn about these young men, at this time only young men, conscripts in great detail. And what these investigators did is they followed a cohort of men who were conscripted into the service over an average of 19 years, a median of 19 years, up to 22 years, but most of them were in the sort of 18 to 22 range. And Sweden, of course, has this wonderful patient registry that allows for epidemiologic research, that like nothing we have here. But the investigators consulted the hospital registry and looked at ICD-9 diagnoses of traumatic brain injury. And they found that when they looked at this, that 4,700 of the men had sustained a traumatic brain injury before they came in for their 2-day baseline evaluation, so during childhood or adolescence or their very early 20s. After, there were 12,000 men who sustained one or more TBIs, who did not have, they identified people who had a subsequent TBI after conscription evaluation, but not before. And so then, of course, that left to 280, almost 289,000 men who had no history of TBI either before or after. They also had several hundred pairs of twins, of whom 63 were discordant for TBI. So that allowed for another very interesting analysis. So here's what they looked at. They looked at cognitive testing. On IQ testing, compared to the 289,000 men who never had a TBI before or after conscription, those who had one prior TBI scored 5.6% lower, about 3.5 IQ points. Not much, a little bit. So you'd think, well, that must be an indication of their history of TBI. After all, they had a brain injury, and you'd expect maybe a few point drop in IQ. But look at what they've also found, that in the even larger sample of men who didn't have a TBI before conscription, that is, the 12,000 who did after, that those with at least one TBI had an IQ test score that was 5.3% lower, about almost the same. That could not have been caused by their TBI, because the baseline evaluation took place before the TBI. So the implication is that the 5.6 reduction in performance on that cognitive testing among those who had a TBI earlier had nothing to do with their TBI. It was simply a reflection of the risk of having a TBI. So They also found that both members of the twin pairs who were discordant for TBI had lower scores on a couple of the IQ subtests, but they didn't differ. So whether the twin had a TBI or didn't have a TBI, these are mild TBIs, mind you, they did not differ in their baseline performance. They also found several other factors in the histories of those who had TBIs. These men, those with fewer years of education, lower income, those who had been, some of them had been admitted to a hospital for intoxication. They were at increased risk of having a TBI. And men who were extremely physically fit, the most physically fit, were also at higher risk. So when they looked over the whole 306,000 conscripts at their IQ test performance, and they stratified performance into deciles, the lowest 10%, the next highest, next to the very top 10%, what you see here is that the lowest, which is in the light blue, had the highest risk of a TBI. And those with the highest IQ scores in that sort of olive green had the lowest risk over time. It's a monotonic relationship. Every slight decrement in their cognitive performance increased the likelihood of having a TBI over the next 20 years. So there are some very interesting and important limitations in research in this area. One of them concerns ascertainment bias, from usually resulting from recruitment strategies. It's very important, if you're going to do research in this area, to recruit people because they had a head injury, not because they're presenting to a clinic for some kind of concussion treatment or, so forth. You want to get people because they had a head injury. That's not easy. The best way, of course, is to do it in an emergency room. But even that's not fully representative, because most people with an mTBI never go to an emergency room. It's estimated that fewer than 25% of people who have a mild TBI actually go to an emergency room. Lots of times they pick themselves up, dust themselves off, and just keep rolling. Another problem is that people will use healthy controls. So if you have healthy controls and people who have a traumatic brain injury, they're differing not only by virtue of having a brain injury, but by having trauma. So it's very useful to get people who've had non-TBI trauma so that you can isolate the effects of the TBI rather than just having a traumatic injury, period. Third is the failure to account for litigation status. Very few studies will report how many of the participants in their studies were engaged in a lawsuit or a disability claim, and likewise, they often fail to include tests of performance validity. And we know from many studies that a small fraction of people will fail these performance validity tests, whether they're just not engaged or they want to tank them or whatever. So, returning to the outline, I want to talk next about the natural history of cognitive recovery following mTBI. A few studies have found statistically significant, but pretty modest, persisting cognitive effects following them. And most of these studies are older. They often didn't use the best recruitment strategies. Many of them used elderly adults. So you can sort of see effects of persisting cognitive problems in some studies. But several meta-analyses, which aren't, so that instead of cherry-picking individual studies, looking across studies have been published. In fact, quite a few. And we published one a little over 20 years ago. And we reviewed 39 studies of people who were recruited prospectively in an emergency room and had an mTBI. And we looked at the effect sizes, and we stratified the effect sizes by time since injury and also by injury severity. And we found that across all time spans, those people who had a mild TBI showed an effect size of about 0.24. That's 1/4 of a standard deviation on overall cognitive testing. 1/4 of a standard deviation is between 3 and 4 IQ points, which is, by the way, measurement error for the IQ test. You can show that much variability just being tested twice with no injury. Of course, it's more severe, more like 12 points on average for people with moderate to severe. But when you look at it broken down by time, you can see that in the mild TBI, you can see effects that are moderate or close to moderate, 0.41, during the first few days after an injury, but it moderates pretty quickly within, the first month. And by 3 months, by 1 to 3 months post, people are really not distinguishably different from zero. The zero is the line of the controls for across all these studies. So, as I mentioned, several other meta-analyses have been done, and Justin Carr did a very interesting review of meta-analyses. So meta-analyses review studies. Justin Carr reviewed meta-analyses, and he found that the effect sizes over here in this column, it's not very easy to see, but they range from like 0.06, which is close to zero, to 0.81, which is a very big, that's considered a large effect size. But that one study with an effect size of 0.81 was from Brolio et al., and they tested patients 3 hours after their injury. So you can see a pretty significant effect just a few hours immediately after a mild TBI, after a concussion. But those same authors, when they tested them 2 weeks later, they found that the effect size was 0.24. That's the effect size that we found back in 2003 across studies. And when you exclude that 81, that 0.81, and replace it with their 2-week finding of 0.24, then the overall effect size, the unweighted mean of these, I didn't weight them by sample size or anything, is 0.3, which is actually pretty close to what we found, 0.25. Okay, that's on psychological or neuropsychological testing, but what about in the real world? I want to talk about this very interesting study that was done here at Hopkins in our School of Public Health. And they examined the batting statistics for 77 Major League Baseball players who had a concussion during the 2011 to 2015 seasons. So these were players who had at least one or possibly more than one mild traumatic brain injury during season. And they compared their batting average, their on-base percentage, their slugging percentage, on-base plus slugging, base on balls, which are walks, strikeouts, home runs, all per times at bat. And what they did is they averaged their performance for the 60 days prior to the concussion, and then compared their performance after they returned to play. They returned to play an average of 11 days later. So they were off for 11 days for recovery. Then they came back and they returned to play. And the authors looked at all those batting statistics for the first 2 weeks after they returned, for the first month after they returned, and for the first 60 days after they returned. Note, side note, hitting a pitch thrown by a major league player is almost impossible for ordinary human beings. You have, across all types of pitches, on average, just over 1/10 of a second after the ball leaves the pitcher's hand to calculate in your mind whether that ball is going to cross the plate, whether it's going to cross high, low, inside, outside, how fast it's coming at you, and swing. You have 0.125 seconds to make that decision. I can't imagine a neuropsychological test as demanding as that myself. Here's what they found, and I'm just going to highlight one thing. When they looked at the 60 days pre, and then they looked at the batting averages over those 2-week, 30-day, and 60-week epochs of time after they returned to play, batting averages dropped by an average of 8.66. So if you're batting the average NFL or MLB players' batting average is around 250 roughly. So that means that they get a base hit or better 1 out of 4 times. It's not easy to do, even if you've never had a brain injury. But let's suppose your batting average was a little better than most, and it was 289. And then during the first 2 weeks after you returned to play, it dropped by 8 points. So it went from 289 down to 280, roughly. That was the acute effect of the TBI. By 30 days, your batting average improved by 3 points. You went from 289 to 291. 292, my math is off. And by 60 days, it went up by 5 points. All the other measures are the same, except base on balls, which are walks, basically, and those aren't affected either way. But in all the other respects, performance declined a bit during the first 2 weeks after they returned to play, but quickly bounced back and actually improved. So let's talk about claims and facts. There's a very common claim that I've encountered in doing medical legal work that mild TBIs cause permanent cognitive impairment due to irreversible brain damage. People will use imaging and neuropathological studies to document that there's irreversible brain damage, and that is the basis that is presumed to cause them. But the fact is that both cross-sectional and longitudinal studies, as I showed you just now, demonstrate that athletes typically return to baseline cognitive functioning within a couple weeks, a week to 10 days. Football players, it's usually 7 to 10 days for athletes return to their baseline performance on cognitive testing. Maybe not quite as sensitive as actually playing the game. Non-athletes might take a bit longer, 30 to 90 days, but the residual effects from mTBI are less than 0.1 to 0.3 standard deviations, or between about 1.5 and 4.5 IQ points. But remember the Swedish conscript study. Those actually might simply be indicative of a risk for having one. Of course, many of us, probably the vast majority of us, will have, if we have a traumatic brain injury, it's through no fault of our own. It's purely an accident. You get rear-ended, something like that. But there's a substantial minority of people who have a head injury, young men who say, hey, watch this. So next I want to talk about this whole notion of post-concussive syndrome and acute and prolonged. Now, acute post-concussive symptoms like headache, nausea, vomiting, dizziness, light sensitivity, these are very common after a TBI. They are not diagnostic of a TBI, but they're very common. And so you can see these acute post-concussive symptoms, but in a small fraction of the population, maybe 10, 15%, they persist, sometimes for months or years, sometimes even longer. And it's often thought the patients themselves will usually attribute it to the TBI, and many of their doctors do too. It's very common for me to read medical records from physicians who say that the patient had a concussion back then and is having, persisting post-concussive syndrome, even though the doctor never knew whether the person had a Glasgow Coma scale of less than 15, whether they ever had any altered consciousness at all, whether they had, anything, because patients will just tell them I had a head injury. So the report of these symptoms can correlate with performance on tests. Like during the first few days or weeks or hours, if someone says, I just can't think clearly, I can't focus, I can't remember things, that may well be due to the head injury. But over time, those people who report persisting problems with concentration and memory and forgetfulness and so forth, their complaints stop correlating with performance on testing. So in the acute phase, cognitive complaints and cognitive test performance often go hand in hand. Down the road, they become uncoupled. So people will have complaints, but they won't show that on neuropsychological testing. So there are lots of questionnaires that are out there, and as I said, many physicians will infer a history of mTBI from reported symptoms, even with no clear history of one. But it's important to recognize that these symptoms, PCS, are very subjective, they're very nonspecific, and they're quite common in the normal population, just in the general population. And in fact, the evidence that I'm going to show you demonstrates that mTBI is much less predictive of PCS than psychiatric disorders. Having a psychiatric illness is far more predictive of PCS than having a concussion. Here's one of them. This is a neurobehavioral symptom inventory. It's very small, but you might be able to see at the top of the slide, there are symptoms like feeling dizzy, loss of balance, poor coordination, and so forth. But as you get down to the halfway point, loss of appetite or increased appetite, poor concentration, can't pay attention, forgetfulness, can't remember things, difficulty making decisions, fatigue, slowed thinking, trouble falling asleep, feeling anxious or tense, feeling depressed or sad, being irritable, being easily frustrated or impatient. How many of us do not have some of these from time to time? Here's the Rivermead PCS questionnaire. That's widely used throughout the world in research. And again, it has a smaller set of symptoms, but there are many of the same: dizziness, headaches, noise sensitivity, and so on and so forth. But they also have lots of mood symptoms that are very typical, not just of mTBI. So Daphne Vermeulen and colleagues did this wonderful, published this wonderful study of an online survey. They surveyed almost 12,000 adults from Italy, the Netherlands, and the United Kingdom. And they gave people the Rivermead PCS questionnaire. And they defined PCS as anyone who endorsed at least 3 or more symptoms at a level of 2 or greater. So not 0, not 1, but either a 2, 3, or 4. And so that defined whether someone had PCS. But look at what they found just in terms of the symptoms. Almost half the people reported struggling with fatigue over the preceding month. Almost as many sleep disturbance, feeling frustrated or impatient, being irritable, easily angered. The ones that are the most common are the ones that are most nonspecific. Suzanne Mears published a wonderful study, now it's quite old, published in 2008. And what she did is she recruited 2 groups of patients. One group of patients came into the emergency room for a mild traumatic brain injury. They had clear evidence of a mild TBI. They may or may not have had bodily injuries. Most of them did have bodily injuries as well. The other group had bodily injuries, but no evidence of an mTBI. So it was either mTBI plus bodily injury or bodily injury alone, no TBI. And they interviewed them in the emergency room. They took a history from them, and they asked them if they recruited them in the study, if the patient said they'd be willing to return for a follow-up. So then they followed up 5 days later, and they gave them the Rivermead PCS questionnaire, and lo and behold, 43% of the mTBI patients and screened positive for post-concussive syndrome. But so did 44% of the people who never had a head injury. And in fact, both of those, 43 and 44, remind you of something? That's what the population base rate was in an online survey of 12,000 adults. So when they did multivariate analyses, logistic binary regression, they found that having a TBI wasn't predictive at all of whether someone developed post-concussive syndrome. It conferred 0 risk. Female gender and reporting a history of anxiety or depression when you were in the emergency room, that's what predicted whether people had PCS. Now, they didn't account for all that much variance, but those were the only things that did seem to account for it. Alison Donnell and Greg and Rodney Vanderplug published a wonderful study based on the CDC's Vietnam Experience study. This was a non-clinical, population-based follow-up study of almost 4,500 male U.S. Army veterans who entered service during the Vietnam era. They came to one of 3 or 4 sites around the United States. They flew in, drove in from all over the country for a 3-day evaluation. Very comprehensive. They got a diagnostic interview schedule or some structured psychiatric interview. They had filled out tons of questionnaires. They got all kinds of studies, cardiac, pulmonary, you name it. It was extremely, because they were concerned about things like Agent Orange and, all kinds of stuff. So this was a very, very thorough workup. And although they didn't give a Rivermead PCS questionnaire because they weren't being done at that time, they did record many of the symptoms that comprise post-concussive syndrome, the so-called post-concussive syndrome. And so they went back through the charts and made an archival diagnosis based on the same threshold of 3 or more symptoms being reported. And here's what they found. They found that if you had an mTBI, that you were 3 times as likely to report, to screen positive for post-concussive syndrome. So clearly that was a risk factor in this study, but the only one it exceeded was alcohol abuse or dependence. And that doubled the risk. But look at this. If you had depression, generalized anxiety, and PTSD, you had a 71-fold increase in your odds ratio. And in fact, all of the psychiatric disorders conferred a much greater risk in this study of PCS than concussion or mTBI. Finally, on this topic, I want to talk about a study that was conducted in Lithuania. And it was, again, this was a little bit older study, 2004. But it's a very interesting study because at that time in Lithuania, the legal structure was such that there was very little opportunity for compensation, even if you were rear-ended by another vehicle and you had a head injury. So there just wasn't a litigation kind of incentive. Okay. And what they found was that 41%, so they compared 217 people who had one with 220 who did not, and the mTBI group reported, 41% of them reported having headaches during the year before their accident. 66% of the non-TBI trauma controls did. So it's almost as though they were retrospectively reporting fewer headaches before their accident than people who had other injuries. Same thing with dizziness. But by 3 months post, by 1 year post, the groups did really not differ in any after you apply a Bonferroni correction, except for one, being worried about having a head injury, a brain injury. And so on this study, this was a World Health Organization task force that reviewed multiple studies of outcomes, and they found that cognitive deficits and symptoms are common acutely, that most PCS symptoms resolve within a year, that when they persist, the most common predictors are compensation or litigation, and that the task force recommended replacing the term post-concussive syndrome with post-trauma. So what are common causes of it? I suspect that the initial response to acute symptoms heightens focus on them. And this can increase a tendency to attribute new symptoms to the mTBI and decrease the salience of pre-injury symptoms. It's called a recall bias. There's lots of research confirming it, sometimes called the good old days bias. Pre-existing anxiety and depression, or a proclivity to sort of focus somatically, could be another cause. And finally, the effects of litigation, and in some instances, frank malingering. It's just when you file a lawsuit or a disability claim, there's a big cognitive dissonance to say, I'm fine, and I'm filing a suit for $1 million. So finally, the future risk of dementia. I want to just describe 2 very quick studies. This one was by Brenda Plasman and colleagues. This is from the Duke twin study. This is a wonderful registry of World War II veterans who were all twins. And they got the Jason Brandt's telephone interview of cognitive status modified. And the scores range from 0 to 50. Scores below 28 are suspicious for dementia. And they looked at the veterans who did and did not have a TBI. And what they found is that the baseline tic scores for both the TBI and non-TBI group were virtually identical, 32.5, even though the TBI group had their TBI 34 years earlier. So after 34 years, their tics performance was no worse than those who had a TBI in the remote past. On follow-up testing, when they followed these folks longitudinally, that at age 70, the TBI group scored about a half point lower on the tics than the non-TBI group. And they found that the slope of their decline was 0.02 points faster. Statistically significant when you have thousands of people, but clinically pretty trivial. And then finally, this study looked at this is a systematic review, meta-analysis. They looked at the population attributable risk of dementia due to TBI. And you can see that in a population where there's an estimated risk of dementia of 6.2 million people, that about 860,000 of those might be attributed to a traumatic brain injury. But remember, these are brain injuries of all severity: mild, moderate, severe, catastrophic, you name it. And so, in fact, the percentage, the risk is 0.7% of, even if this is accurate and even if it applies to mild TBI, and there's no clear evidence that it does. So mild TBI, defined by signs, not reported symptoms. The people who sustain them tend to differ from the population by age, sex, IQ, education, behavior, and more. Cognitive deficits following TBI are modest acutely and minimal by 1 to 3 months, by 3 months post-injury. Prolonged symptom post-concussive syndrome is probably a misnomer and should be discarded. It usually results from recall bias, other psychiatric disorders, or litigation effects. The risk of dementia due to mTBI is greatly exaggerated, and Mr. N exemplifies virtually all of these findings.
Thanks so much, David. Fascinating. We just have a brief time for questions. There's a lot to talk about here. But I just want to focus on the Major League Baseball results, which partly because I'm a sports fan, but partly because they were counterintuitive. The fact that people actually did better, what was it, a month and 2 months later, than having had a TBI seemed to improve performance over time. And I assume that's an aberration, or is there a reason to think that could be something?
I don't know what it would be, but one possibility is that simply continued playing and continued experience improves your batting averages. I don't know. The increases, remember, were in the third decimal point. It's like from,
There's no reason to think that a mild TBI could actually be beneficial in any way.
Probably not.
Okay. Doesn't seem terribly likely. Folks have questions? Dr. Margolis.
Yeah, I very deliberately omitted any discussion of CTE from this talk because it's such a vast topic, and it really is a talk all by itself. And so it's hard to give us a quick answer to that. But briefly, a lot of people have suggested that a cardinal clinical feature of CTE is depression and suicidality, because we've had a number of major NFL players commit suicide, and quite conspicuously in the media. And in fact, there's some suggestion that NFL players, that the overwhelming majority, maybe 99% of them who come to autopsy in midlife, have evidence of these neuropathological changes that are indicative of CTE. But if almost all of them have them, and one of the features of CTE is depression severe enough to cause suicidality, you'd expect NFL players to commit suicide at a higher rate than the general population. But in fact, their suicide rate is lower than the general population. So it's hard to reconcile how close to 100% of players have these neuropathological changes and CTE, which increases your risk of suicide, when the rate for them, their suicide rate, is actually lower than the population in general. So I think there's a lot we have to learn about CTE and what's in the denominator. You can put NFL players in the numerator, but we don't know. I haven't seen good studies of middle-aged men who are depressed or committed suicide, who had problems with alcohol, to look for the same pathological changes.
Thanks. Dr. Morrow.
My question is very simple. It's not multiple mild TBI.
There have been several studies, well-designed studies, that look at having 2 or more TBIs. The results are a bit mixed. In some cases, they do find a little bit more residual cognitive dysfunction, but in others, they find none.
With that, go ahead. Yeah.
Do you know if there's a difference
Yes, that is becoming more recently. There's more recent studies of older adults because, of course, due to falls and other accidents, it's not uncommon in later life. And the findings are kind of mixed. Some findings show that they're really no different than younger people, but other findings do show that they can have their deficits persist longer. Not necessarily that they're larger, but they can persist longer. The one recent one showed that at 3 months, they still had substantial effects, an overall effect size. And I think it was actually close to 0.7, so it was pretty significant. But they didn't study them at 6 months or 1 year, so we just don't know that much about it.
With that, we will wrap up and thank Dr. Schretlen for a terrific Grand Round.